I'm glad to be here. And I like to start off any regulatory conversation with a little bit about terms that I will use frequently as we move forward when we're talking about the 2025 regulatory landscape. So, understanding the terms related to agency, department policy, goals, regulations, and rules is crucial for navigating the regulatory landscape. Each of these elements plays a distinct role in governance and compliance. Agencies are responsible for implementing policies that align with broader departmental goals, and while regulations provide the specific rules that govern the actions within those policies. So basically, there's three that I want to talk about: agency, policy, regulation. A policy serves as a foundation and can be implemented through various regulations. For example, a policy might aim to put patients first and ensure that they have information they need to make well informed healthcare decisions. So, this policy would be implemented through regulations, such as setting price controls on prescriptions, drugs, or requiring insurance companies to cover certain preventative services. So, an example of such regulation would be CMS 9915 F, the final rule titled Transparency and Coverage. So you can see the policy is the overarching or underarching foundation that many of the rules and regulations are structured around. So it's a many to one type relationship. The agency is the department that sets those rules and uses the policy or their goals in order to set what regulations and rules they'll want to be implementing. Another kind of disclosure type thing related to terms, a presenter's code of conduct. When I looked this up related to acronyms, because when you start talking about the regulatory world, acronyms just roll off my tongue. It's kind of like in today's world of text messaging with acronyms that are frequently used, things like LOL and SYL for see you later. When talking about government rules, regulations, etc., acronyms are probably more frequently even used than in text messaging. So I wanted to do the right thing and disclose up front. So here is a list of the acronyms that you will see in today's presentation and may roll off my tongue in one way or another, but I've tried really hard to at least include most of them in the slides themselves. But here are the ones that we'll talk about today. So, with that said, now moving on to something a little bit more dry. Here are a list of the current federal departments/agencies within the executive branch of government that are all part of this regulatory landscape. Since this is a HIMSS event, and we focus most of our conversation today around healthcare. We're going to focus the conversation, the remainder of this presentation, on the Department of Health and Human Services portions, which is HHS. Little background on HHS. Back in 1953, the cabinet level Department of Health, Education, and Welfare, HEW, was created under President Eisenhower, officially coming into existence on April 11th of 1953. And then in October of 1979, the Department of Education Organization Act was signed into law by Congress, providing for a separate Department of Education. So they pulled the Department of Education out separately, and then HEW was redesignated the Department of Health and Human Services, and HHS officially arrived on May 4th, 1980. Basically, the cabinet is a series of departments within the executive branch of government that are meant to advise the president on issues related to their respective offices. So since we're going to focus on HHS, I'm going to dive a little bit deeper into HHS. Its overarching goal is to enhance the health and well-being of all Americans. We can't talk about HHS at all in 2025 and not discuss some of the restructuring that is beginning to take place or started taking place in early 2025. It kind of started, here's a timeline with on February 11th with the Executive Order 14210 titled the Department of Government Efficiency Workforce Optimization Initiative. Many of you have heard of that a lot in the news. And it kind of spurred several things that happened then in the department in HHS. So February 13th, just a couple of days after the executive order, Robert F. Kennedy was sworn in as the secretary for the HHS, and Executive Order 14212, titled Make America Healthy Again, was also signed into action. Then about a month later, March 11th, HHS Office of General Counsel announced its reorganization effort. The end of March, March 27th, HHS Secretary announced significant changes and restructuring, followed a few days later on April 1st with what HHS initiated to reduce the federal workforce in their department. We're going to focus a little bit on some of that that happened there on April 1st. So basically that reorganization restructuring was a consolidation of 28 HHS divisions into 15, reducing HHS regional field offices from 10 down to 5, and then reducing overall HHS staffing levels from 82,000 to 62,000 in departments such as the FDA, Food and Drug Administration, CDC, and CMS. So I'm going to go through this next part pretty quickly, but we're talking about the consolidation of government of HHS offices. And so one of the first things was ASPR, the Administration for Strategic Preparedness and Response, used to be a department on its own, and it now moved under the purview or control of the CDC. A new operating agency was created called the Administration for a Healthy America with a purpose to consolidate OASH, HRSA, SAMHSA, ATSDR, and NIOSH. NIOSH was previously under the CDC, and now it's been pulled out to be under this new operating agency called the Administration for a Healthy America. So I'm pulling these departments out of the original structure on the left-hand side of your screen, and I'll be talking about them and putting them into their own little structures on the right-hand side so you can see how they pan out. What I don't know is how the final reporting structure through the governance of the HHS will pan out until the new org chart is released. But so that's why I'm pulling them here and just kind of leaving them as separate entities as I begin to talk about those changes. There was a new assistant secretary for enforcement appointed, and they will be overseeing the DAB, OMAH, and OCR. I pulled those out over here. Then there was the creation of the Office of Strategy with a goal to enhance research that informs policies and improves the effectiveness of federal health programs. That Office of Strategy, they're going to merge ASPE and AHRQ into one. So it'll look like that. And then they are reorganizing or removing the ACL. So they're moving agencies that support older adults and people with disabilities into other HHS agencies. So ACL will then kind of disperse and their efforts will then be covered by the ACF, ASPE, and CMS. They created a new Office of Healthy Futures with a goal to create a single innovation hub that accelerates the path for biomedical discovery to impact. They're going to merge Barada and ARPA what I understand from reading the reorg structure and all of the information is it's not necessarily going to be a new office or entity, but more of a concept that's been created to be able to advance the progression of the of biomedical device discovery. So that's the movement within the government, and I don't want to focus too much on that. Because it's still kind of unfolding. I want to talk a little bit more about the agency examples because it's a big, give you some examples of agency work because they're big parts of the regulatory landscape, especially in healthcare. So we're diving deeper now into the weeds of some of the agencies that create and enforce the regulations of our healthcare organizations and our providers. They need to stay very aware of these rules, not necessarily the structures, but more about the rules that the agencies are implementing. So here's a few of the regulations where they fall into the various departments. I've designated with blue horizontal areas, and I've called out just a few that we will talk about today. So HIPAA on the upper right-hand side of your screen, that falls under the OCR, or the Office of Civil Rights. It's one of those departments that's now been pulled out and is under the Assistant Secretary for Enforcement. Then we've got Promoting Interoperability, MIPS, MSSP, et cetera, kind of fee for service type regulations. Those will still remain under CMS, which has not necessarily moved, but has it's received some added scope and bandwidth from the ACL dissolution. And then we've got down at the bottom left-hand corner, the Certified Electronic Health Record Technology, CEHRT, information blocking, interoperability rules, and standards such as TEFCA. And those all fall under the ASTB ONC department. Going to focus a little bit on that. ASTP stands for the Assistant Secretary for Technology Policy, and the ONC is the Office of the National Coordinator. So the ONC was what originally started back in 2004, and it was created via an executive order. Then it was later legislatively mandated in the High Tech Act of 2009. It was the restructure was kind of aimed at streamlining policy and strategy, planning for technology, cybersecurity, data, and AI that is now finding its way into healthcare. Ultimately, it's focused on coordination and information sharing, as well as ensuring patient health records, or PHRs, remain secure and shareable. Some of the regulations that fall under the policies and the agency of the ASTP and ONC are the 21st Century Cures Act. It was basically passed in 2016, and it went fully into effect in 2021. It included the first rule related to information blocking and the structure and mandates for TEFCA, Trusted Exchange Framework and Common Agreement. TEFCA was mandated in the 21st Century Cures Act to promote nationwide healthcare information exchange. You hear a lot in healthcare about interoperability, and TEFCA was kind of some of the standards and ideas that were brought about to really help exchange health information within the country. The ONC, Office of National Coordinator, launched a voluntary certification program in 2010, CEHRT. However, While it's voluntary, there are government programs like CMS that require an organization to use CEHRT or not be able to participate. So it's really only voluntary from a vendor perspective. If you are a vendor of software and you choose, you volunteer to get your software certified, that's where it's voluntary. But there are other rules and regulations that tie in that require you to use certified electronic health record technology that tie to other programs, which we're going to talk a little bit about. But as I talk about some of these rules and regulations, these agencies, these policies, you will hear a lot of what I call the spaghetti effect, where one agency has a rule, a regulation, or policy that informs and drives rules and regulations that are managed and overseen by other agencies within the HHS department or organization. Okay, so CMS is another agency in there. There's two rules that are around interoperability. We talked about that being interoperability being part of ASTP and ONC, but there it flows over into the CMS department, and those are the interoperability and patient access rule and the interoperability and prior auth rule. Both of those have a large focus, as you would expect from their name, on that interoperability piece, and they're really designed for exchanging health information as well as a focus on patients accessing their own health records. Two rules that you've probably heard about, and both are related to the Medicare fee for services. One is the IPPS rule, and one comes from the PFS rule. The IPPS rule touches many pieces of inpatient acute care and critical access hospitals and includes regulations around promoting interoperability, or the old meaningful use rule. So now meaningful use is known as or called promoting interoperability, but I like to kind of refer back, because if you don't pass the promoting interoperability rule, then you're designated not to be a meaningful user. So they still have the terms mismatched and spaghettied around in the industry. The QPP, or Quality Payment Program, MIPS rule, which is part of the PFS rule, contains similar performance requirements for PI, promoting interoperability, as well as the cost and quality. These two rules, they contain performance standards related to the use of certified electronic health record technology. They have performance standards for interoperability with public health agencies and electronic clinical quality measures, just to name a few. So, now that I've talked a lot about just in a couple of slides, I've probably thrown a whole bunch of acronym soup at you. Hopefully, I'm continuing to, I can always refer back to my original slide, but I'm hopefully, if you guys have questions, write them down. If I throw a term out there that I didn't clarify what it was, I'm happy to try and answer that question at the end of this presentation. All right, we've talked about agencies. Now we need to talk a little bit about regulations and the regulation process. So there are three phases of of introducing a regulation or a rule. There's the pre-rule phase, there's the proposed rule phase, and then there's the final rule phase. In the pre-rule phase, first the agency must be granted authority to issue a rule. They have to submit advance notice of the proposed rulemaking, typically submitted through to the Federal Register. And then, if warranted, then the agency proposes its findings to Congress or to the President, and they obtain official authority. Next comes, once that authority is obtained to actually propose the rule, then becomes the proposed rule phase and it starts off with a notice of proposed rulemaking, or NPRM, and it's typically published in the Federal Register, or FR. Usually there's also included a 60-day notice for public comment on that published NPRM, sometimes more, sometimes less, depends on the rule. And we're going to talk a little bit later about how that might change um, differently than it has been over the last several years, with that public comment period maybe not happening as much as we're used to. Then after public comment is over, the agency begins to review all the comments that they've received. They conduct a comment analysis, and then they make their final determination in that final rule phase, where as to whether or not to proceed with the rule as proposed, issue a new rule, or issue a modified rule in that final rule. So you can actually have new proposed rules, new rules, finalized rules, or modified rules in the final rule without going back through the whole process. All right, there's another way to get rules in and entered, and that would be an executive order or an EO. An executive order is a directive issued by the President of the United States, and it doesn't require congressional approval. This means that the President can implement certain policies or actions directly without needing to go through the legislative process. Executive orders are often used to manage operations within the federal government or to address specific issues quickly. And I've given you some examples of those EOs in that timeline slide where we talked about the initial executive order for making America healthy. Uh, at the bottom of this slide, I do have some links, and I've included some throughout the presentation with references to what I'm speaking about. And on this slide, you can go out and see a list of all the EOs that have been implemented since the beginning of tracking EOs and the beginning of time by president and by number. Okay, to get back to the 2025 landscape, now that we've covered just some general information about the regulatory process, about some of the agencies, and some examples of some of the rules, I really wanted to hone it back to what's happening in 2025 related to all of those things and people that we just talked about. So, in late December, December 27th of 2024, there was NPRM. Remember, that's Notice of Proposed Rulemaking. And that NPRM was officially published in the Federal Register on January 6th of 2025. So I get to include it because that's when it was official when I'm talking about 2025. So comment period for that rule closed on March 7th of 2025. And then to give you an idea of how that rule process works, we're expecting a final rule for that HIPAA security rule about 180 plus days after the comment period closes. That gives the agency time to review all of the comments, make their final decisions, and then publish the final rule. So we're expecting it to happen in September or later. So far, when I looked online the other day, there were over 4,700 comments that the agency OCR will have to sift through before they make their final decisions. The HIPAA security rule modifications are aimed to be able to increase increase the cybersecurity for electronic patient health information and address some common deficiencies. They've seen over the last several years since the HIPAA security rule came out, they've seen significant changes in technology. They've seen changes in breach trends and cyber attacks. The OCR enforcement experience. So when they're enforcing the security rule, they've gleaned a lot of information on practices that are out there that they've had to enforce against or with or for. And so they've consolidated some of those lessons learned. They've also identified some other guidelines, best practices, methodologies, procedures, and processes for protecting EPHI. And they've taken into account some court decisions that affect that enforcement of the security rule. So it's a large rule, and it is due to come out, as I mentioned, in September. I just this morning saw an announcement where they're holding a seminar to really talk about that proposed rule, and it should be. I recommend people watch it so you know how it will or will not affect your organization, and what you're doing related to the HIPAA security assessment practices. All right. Then there is the IPPS rule, and I'm not going to read out what IPPS stands for. Basically, it's Inpatient Prospective Payment Systems, but the title of the rule is much bigger. It was released. Now, this is a proposed rule. It was released in April, the end of April of this year, and I'm going to summarize a little bit about some of those changes. So it was 1,361 pages in length, just to give you an idea of what we're talking about when we talk about a proposed rule. This rule is required by legislative law that they have to release a new IPPS rule every year. And so this is a yearly release that is 1,361 pages in length this year, if it gives you any idea of the amount and the volume of information and regulations that are covered in that particular rule. It did have a comment period, which ended on June 10th. For those of you that are receiving Medicare funding and participating in promoting interoperability programs, here are some of the proposals in the rule that you might want to think about. And the ones that I have bolded on the slide are ones that you can tell are in relation to that spaghetti effect of other rules and regulations that are currently in place. So they have proposed to modify the security risk assessment measure of the promoting interoperability role in the IPPS rule that ties to the HIPAA security rule, that you have to not only do an attestation that you've done a security risk assessment each year, but now there's a second attestation they're proposing that says that you also have to have conducted a security risk management. So no longer just an analysis, you also have to attest that you're managing to that security risk assessment. And they're proposing that new attestation start in 2026. When these new rules come out, these proposed rules come out, it's really important that you take a look at when they're proposing things start. Well, as I mentioned, this came out in April, and some of the proposals, as you'll notice the next one down, are retroactive back to 2024. So you have to really pay attention when you read these 1,361 page long regulatory pieces of information, so that you can figure out what it means to you, to your organization, and when you are going to be held accountable for various pieces and parts. So the proposed removal of HE and SDOH measures and COVID-19 vaccination coverage for healthcare professionals, that one is slated to be retroactive back to 2024. While we're talking about, I recommend you continue reporting on the measures, and I would do that anytime there is a retroactive effective date in any proposed rule, because when the final rule comes out, they might change it, and they might take it out, and then it wouldn't be retrospective. And since we're already into the 2025 reporting year, you would then still have to report on those measures for 2025 instead of the proposal to remove it back to 2024. So continue on reporting on those, planning to report on those for the 2025 reporting year. We won't know anything until August about August or September when the final rule comes out. There are updates to claims measures and hybrid measures that are slated to start beginning in the 2025 reporting year. So again, it's proposed in 2025, and changes for the 2025 reporting year, which are already in progress, are proposed in the new rule. They're talking about adding additional electronic clinical quality measures for the inpatient quality reporting programs, stating that it would go from 3 required in 2025 up to 6 required in 2026, and then 8 required eCQMs in 2027. Starting in 2026, they're stating that you must switch to the newer version of the Safer Guide Assessment, which is titled the 2025 Safer Guide Assessment. So in 2025, we have to attest that we did the 2016 version of the Safer Guide Assessment. And then in 2026, we'll be attesting that we did a 2025 version of the Safer Guide Assessment. Starting in 2026, they're talking about adding TEFCA for public health reporting as a bonus option. And then also starting in 2026, they're talking about mandating the use of things of the standard US CDI version 3, which includes additional things such as health insurance information, health status assessments, and more details related to medications. Currently, they just say you have to be able to exchange medications, and now they're adding things like dose, units of measure for your dose, indication for the medication, fill status, etc. They're going to add more demographic details in version 3, things like occupation, tribal affiliation, date of death, adding reason for referral, and just to talk a little bit about how that ties together, that 21st Century Cures Act final rule that came out in 2016 that went into effect in 2021. It initially referenced version 1 of the US CDI dataset, and so this is moving us up to version 3, which is finalized. And just another piece of information, I think they're already up to the proposal for version 6, so we're even behind in the versions that they're building into the regulatory requirements. This feels like I'm speaking acronyms, and I don't think it's all about acronyms, but there's so many references to other places that it gets really confused. Again, the bolded ones are modifications that are really recently proposed that tie to other executive orders, like the health equity rule that was initially related to the executive order that Biden put in place, Executive Order 13985. And it was rescinded with Trump's executive order that revoked the 67 previous executive orders and then other prudential memorandums. And so it removed the requirements for the programs to include health equity and social drivers of health. And so now they're having to pull it out of the current rules and regulations, which is why they're trying to make it retroactive back to 2024. Okay, that was a lot. All right, PFS, physician fee schedule, is where the merit-based incentive payment system performance measures are. That is the MIPS program. Luckily, this is a short slide. The rule is not yet out. Again, it's an annual rule. We usually see it released in and around July of the reporting year. It usually has a comment period, so that means 60 days later, and then about 180 days after they've come up with compiling all the comments to the rule, they publish the final rule, which means the final rule comes out in November, just in time to start updating your systems and collecting data that should start on January 1 of 2026. And that's if there isn't anything retrospective in the rule. We've talked about rules, we've talked about regulations, we've talked about executive orders. There's one additional thing that's happened in 2025 that I would just want to talk a little bit about, and that's the policy statement that was released. It's not a regulation, it's not a rule. Basically, it's a statement that outlines the agency's intentions regarding how to handle previous policy and how it's been handled. And this policy, HHS had a policy known as the Richardson waiver that voluntarily subjected certain regulations to public notice and comment periods, which we've talked a lot about, even when the Administrative Procedure Act or the APA didn't legally require it. The policy, the Richardson policy, has been in effect since 1971, and it was established to promote transparency and allow for public input on regulations related to matters like Medicare and Medicaid, among other things. The policy statement in February rescinded the Richardson waiver, opting instead to follow the APA's requirements more strictly and then only conduct notice and comment rulemaking when legally mandated. The decision raised some concerns about reduced public input on healthcare policies and the potential for regulatory changes without sufficient stakeholder engagement. But the rescission gave HHS greater discretion to bypass public input, potentially speeding up policy implementation and aligning it more with the department's view of the APA's original intent. Talked about rules, regulations. Now we got to talk about enforcement. Basically, regulations are enforced by the federal agencies through combination of rulemaking, investigation, and enforcement. And I just want to give you some examples. So here's some examples of HHS enforcement actions. The OCR enforces HIPAA compliance with fines up to 1.5 million for violations. The FDA enforces issues, recalls, fines, and violations for drug safety issues. CMS has penalties for noncompliance with quality standards. CMS publishes those penalties, so you can often see what the fines for noncompliance are or penalties for improper billing by following along with press releases and news results. The 21st Century Cures Act established some of the disincentives for not being for being an information blocker, which was one of the rules that came out in that piece. This final rule for disincentives and how to handle them came out on July 11th of 2024. And basically it ties again to a bunch of other programs. If you're found guilty of information blocking, you would be deemed not to be a meaningful EHR user. And if you're participating in a Medicare Promoting Interoperability program, you could stand to lose 75% of the annual market basket increase, which is basically just an annual market adjustment for eligible hospitals that is determined in that IPPS rule. If you're a critical access hospital, you typically get cost plus 1% in your reimbursement, and you would lose that plus 1%, and you would only be reimbursed 100% of reasonable costs. In the quality payment program, the MIPS program, you would be on the hook for potentially making a 9% negative payment adjustment. Since 2023, in the year of 2023, I'm sorry, 14% of the eligible clinicians that participated in the program did actually see some portion of that 9% payment adjustment. And then Medicare Shared Savings Program, if you were deemed an information blocker, you would be denied the addition of a provider to be a provider for a period of a year in the program. Here's some additional examples that are enforced. Here are some of the claims that are thrown out there for information blocking. Patients have filed the highest claims for information blockers, and healthcare providers are at the top of potentially being an information blocker. So why is all this important? And what I wanted to talk a little bit too about today is governance. As you've seen, there's lots to keep track of in a single regulatory year, let alone the entire landscape of the HHS rules for healthcare organizations. It's really important for you to have a dedicated team of people at the organizational higher levels, keeping an ear to the ground and watching for the approaching lawnmower, that to keep with the landscape thing, to hence the conversation about governance. So governance, it's often neglected in healthcare. There's all sorts of research about it. Many start up and pin up a regulatory governance when things first started, like way back in the meaningful use days. They've been around, they go stagnant, and it's always time to reevaluate or reorg your governance. Examples, originally there was MIPS performance, what affected more outpatient measures, and now there's more and more claims measures that are inpatient and outpatient claimed. Audits are getting more involved, so it's good to have legal and risk at the table. Organization turnover, meaning you started off with this group of people, they left the organization, and now you need to add additional people. And then things like information sharing, you want to make sure there's your privacy officer because of the way that the rules tie together. So you need to have somebody that understands the HIPAA privacy rules, as well as the information blocking rules, as well as health information management and release of information. So here is a list of suggested participants: information technology, quality, finance, legal, compliance, privacy, executive leadership, clinician representation that covers all aspects of your organization, and then informatics. The role of governance is really to help establish the process for how you will stay in compliance, establish organizational goals, resolve conflict, mitigate risk, ensure appropriate resource allocation. It takes time and attention to be aware and on top of these rules and adjustments, and then to communicate. When the changes occur, it's got to come from the top down if there's a change in process or practice, and to participate and to communicate your organization's perspective on the proposed rules, making your voice heard from your organization's governance. We talked about the commenting period, and it's really, really important when the proposed rule come out that your governance and people in your organization really look at what those proposed rules means. Look to see if you understand what they're asking you to do, and then comment back if you're offered that official comment period. I wanted to provide some information on effective commenting. So I use in the healthcare the SBARC uh, nomenclature. So situation, introduce the rule, explain why you're interested in the regulation, highlight positives about the rule, and highlight any experience with the subject. Um, Give a background, a brief section to clearly identify the relevant part of the regulation. Present your analysis, lay out your argument and any evidence. It's important to describe how the rule would impact you and what you care about. And then make recommendations, describe your suggestions for the specific changes that you would advise, and maybe suggest a different way of addressing the same problem that they're trying to solve. And then recap your main argument in a conclusion and list your recommendations again. Next steps for you that are participating and have heard all of this information: stay aware, pay attention to the notifications, check for news and announcements, evaluate the current governance structure within your own organization, ensure you have identified an accountable owner or owners. Do regular report outs of the proposed rules and status, and comment whenever possible. Just a few things that are coming up in the future. On 7/5, it's the last day to start your 2025 Promoting Interoperability reporting. In August or September, we're going to have that final HIPAA rule and probably the PFS rule. And then in November of 2025, the final rule for the PFS rule, which will start as early as a month and a half to 2 months later.